Hi, everyone. Good to have you on. We're just waiting for everybody to join up and then we'll get started. Hi, Josh. Hi, Sam, Jess. So today we're going to be talking about the model for improvement. Just while we're waiting for other people to log on, I'd like you to just enter into the chat how familiar you are with the model for improvement. Are you don't know what it is at all, or you've seen it once, or you've actually used it, or you've been in a project where other people have used it, or you actually know so much about it that and you know that you use something else, in which case what else do you use? So yeah, if you could just enter that into the chat while we wait for other people to join, that'd be great. So yeah, for those who've just joined, we're entering in the chat how familiar you are with the IHI model for improvement. Are you complete, don't know what it is at all, a beginner, used it a bit, or you know it quite well, you've used it before extensively, or you use something else perhaps? Just enter something into the chat about your current experience with the model for improvement. Sam, not very familiar. Luciana, not familiar. Josh, not overly familiar. Okay. That's good. Sally, you've gone through the modules. That's great. Okay, so you've and Sam as well. You've seen it in the modules. Yep. So yeah, we'll be covering what you've learned in the modules, but we'll be sort of exploring the idea and sort of discussing it with each other. Great. Good to have a few more people there just joining just now. So for you guys, we're just putting in the chat how familiar we are with the model for improvement. Are you a complete beginner? Do you know something about it? Have you used it already? What's your level of experience with the model for improvement? Okay, good to see so many of you on the call. And most people here don't know much about it, or been through the models, but been through the modules, but that's about it. So we're going to get started now. Here we go. So I hope you can all see that. If you can't see that, share it out and let me know. You should see the PowerPoint presentation now.
Yep, that's fine.
Great, great, excellent. So I think this is probably one of the more important modules out of the 13, actually, really to sort of like get into the head, because this is probably the engine of improvement and how it's done around here. Obviously, there are lots of ways of doing the same thing, and this is just one, but it seems to be one that's easy, that's ubiquitous, so a lot of people know about it, and it means you don't need to keep explaining yourself if everybody kind of familiar with it or seen it a bit. So this is what we're going to be doing, really. We're going to be focusing on this. This is the model for improvement, and it's 3 questions and then a PSA cycle underneath. Okay, so we're going to be going through each of those questions and what a PSA cycle is. So where does it fit within sort of how you improve? Well, this triangle sort of represents 3 key elements for improvement. You must have the will to improve, and it's not just you, but enough people around you. You must have the ideas, you know, nothing's going to change unless you have an idea for something different. And execution, you must make it real. And this is probably traditionally where healthcare has really not had much expertise. It's kind of been a bit of Heath Robinson approach, where people just kind of do what they thought was made sense, or sometimes just drive it through with diktats and stuff like that. But as our organization becomes more and more complicated, that sort of approach doesn't really work. So that's where the model for improvement comes in, trying to make this a much more successful part of the improvement journey. As I said, there's many different improvement models. You get some in Lean and Six Sigma, and there's actually thousands. And some of them are quite specific to a specific industry or example of something you're trying to improve. But in healthcare, the model for improvement really is probably one of the most well-known and followed one. And therefore, if you're going into an area where you're wanting to improve, or you want to improve something around you, if we all kind of use one model, then we don't need to start right at the beginning where we're explaining everything to everyone all over again. We can kind of start off the conversation a bit further down the track, so it helps. But it's not necessary. If you choose a different model which works better for your specific situation, then you might just need to take a bit more time to upskill those around you before embarking on that improvement through that alternative model. So as I said, it's 3 questions and a cycle. So the first one is about setting an aim. The question is, what are we trying to accomplish? You might have heard of this acronym SMART, making an aim or an objective SMART, which means that it is specific. So trying to really be specific about what you're trying to achieve, maybe putting some numbers around that. Measurable. So you've got to be able to somehow measure it. If you can't measure it in any way, then you're not going to know if it's changed. It needs to be, it needs to be ambitious. So if you set something that's, you know, the change is not much, then what's the point in doing it? But at the same time, it needs to be realistic. You do need to not go for something fantastical, because, well, first you'll struggle to get people behind the idea, and second of all, you'll struggle to actually achieve it. And if you fail, not because the idea didn't work, but because you were just aiming too high, then that's probably an opportunity lost. And then the last thing is time bound. So set yourself a deadline, basically. And things you want to think about, you know, like, you know, how good you want to be, and who is it that you're trying to affect by the improvement, who's going to benefit, and by when, time bound. So pop in the chat, which do you think is the better aim statement, number 1 or number 2? So number 1 says, reduce all types of hospital-acquired infections by as much as possible, as quickly as possible. And the second one is decrease the rate of hospital-acquired pneumonia for patients in the ICU from 23 infections per 1,000 catheter days to less than 5 by May the 1st. I can see that unanimously everybody's saying the second one, of course. Second one is much more specific. It's got some numbers. It's measurable. It's ambitious. I mean, that reduction from 23 down to 5 is, a 5-fold reduction. That's quite ambitious, and it would certainly make a difference to our patients. But it's realistic because the majority of catheter-related infections are due to sort of like infections in and around the catheter that can be prevented. And it's time bound, by May the 1st. Good. So the second question there is about establishing measures. How will we know a change is an improvement? So what are we going to monitor? And that changes over time, and then we say, that's definitely improved. There are 3 types of measures for this. Would anybody like to unmute and describe what an outcome measure is?
How we would determine if it worked or not.
Oh, thanks for trying to contribute, but it just came out a bit broken up there. Your audio connection might not be the best.
Is it the ultimate results, James?
Yeah. So it's what you're trying to achieve in the end. Good. What are process measures?
Those are the measures that are part of the process. So if infection is your outcome measure, number of infections, then there's steps along the way that you might want to measure, like hand washing rates or other parts of the process that you would measure.
Yeah, absolutely. Perfect. And balancing measures.
Tracy here. The balancing measures are where you're measuring the unintended perhaps consequences of an action. So that's that. So you might make a change, but there might be a knock-on effect.
Yeah, absolutely. Perfect. Yeah, unintended consequences. So it's good to think of all the different measures that you would think about in those 3 categories. So yeah, as you guys said, outcome measures is where we're going. And you can think a bit more about outcome measures, because there are good outcome measures and there are bad outcome measures. And it takes a lot of time to actually really choose what the best outcome measures would be. My rules of thumb is, first of all, the less the better, or less is more. If you can actually boil it down to just one really key outcome measure that you're aiming for, that's a lot easier for everybody to get behind and understand. So in that previous statement about catheter-related infections, it was one outcome measure. And the second thing is that it needs to be something that you can visualize. And an example of this was when I was doing a quality improvement project a few years ago on an abscess pathway, where we were trying to, instead of admit patients with abscesses and then do their operation and then discharge them in the traditional way, which would typically involve 2 nights of hospital stay, we were trying to put them on a day case pathway where we wouldn't admit them, but we would book them into a surgery within the next day or 2. And my first thought was the outcome measure, well, maybe the outcome measure should be the proportion of people that have a day case abscess surgery. And currently it was like 10%, and I wanted to get it up to 90%. But that's a bit intangible, on a day-to-day basis with one patient in front of you. It doesn't quite relate to the proportion of overall patients. And what is much more tangible outcome measure, but is almost exactly the same, is the number of patients per week going through to the day case surgery. And the reason why that's more tangible is now that you are got a patient sitting in front of you and you've got a choice to either put them on day case or bring them in. That is one patient that will affect your measure by one. So there's a direct relationship between your behavior and the outcome of the project. So having a tangible measure is better than something that's, statistically just as good, but doesn't quite relate to what you're doing right down there at the front line at the coal face. So that's the other sort of thing that I try and do. Also, with outcome measures, there might be a perfect outcome measure, which is very difficult to measure. It might involve a lot of manual data collection. Or there's something that's a lot easier to measure. Maybe it's something that's already collected within the normal workflow of the hospital, be it either manually collected and recorded or actually put into a database somewhere or on the hospital systems. Again, I would go for practicality over something that's perfect. And I would say, okay, well, this measure here, which we already got access to, is okay. It's not the best, but it's okay, it will do. And then maybe you can supplement that by having some snapshot manual measurements of that perfect measure you want as well, just to prove your point. But the one that you monitor every day is that easier one to measure. And then process measures are important. The last thing to talk about outcome measures is that it's usually quite good to make it patient-centered. And what I mean by that is, if the outcome measure is something that a patient would tell you, yes, I can understand that actually makes a difference to me personally, then that is going to be a much more important outcome measure than other ones. So, for example, in a quality improvement project, you might have an outcome measure that is to do with finance, like the cost of a certain pathway. Or you might have an outcome measure to do with outcome in terms of infections that the patient gets during that pathway. Now, both are actually, the second one there is indirectly related to finance anyway, because we know that hospital care that has less errors in it is cheaper than hospital care with errors. But the second measure there is directly relevant to a patient. And so it gives your project a lot more purpose, because you're getting behind a patient-specific measure. And in the end, that's the thing that unifies us in healthcare, is making things as good as possible for patients. The finance thing is still really important. And so that could be a secondary outcome measure, or it could just be, a process measure. I would maybe even say it's a process measure rather than an outcome, because the outcome in healthcare really isn't to save money, it's to make patients better. So that's it. So it's really important to choose a good outcome measure. You can take quite some time, because sometimes you think an outcome measure is right. So you go to the IT people, they say, oh yeah, we might be able to get that for you. And then they dig around for 2 or 3 months usually. And they come back and say, oh, well, we can't quite measure this. Or they come back with you and it's just not, the data doesn't look right, or it's just junk or something. So it can take a long time to get around this. And I wish there was an easy way to fast track all that, because really the amount of work it takes is not a lot. It's just everybody's wanting this stuff and it can take ages. So yeah, process measures are really useful because they will change much sooner than your outcome measure. You will instantly see process measure changes within a day if you're changing behaviors, like hand washing or something. Within a day you will see that measure change, but you won't see infections change unless you carry that project on for several weeks. So process measures are a really good indicator of you going in the right direction. And they can also show things getting worse before the outcome measure gets worse. So they're good sort of canaries in your project. So say your project's already established and you're now in the phase of sustainability. The process measures are the ones that you want the managers to keep an eye on. And then balancing measures are really important, but they're quite difficult actually. And you have to think more laterally. You know, things like complaints and adverse events and things like that might be your balancing measures. And they're also useful because when you start to get support for your quality improvement project and ask healthcare professionals around you to get behind it, there will be some laggards and cynics who say, yeah, but what if this is going to happen and this is going to be the adverse effect or the unintended consequence. And so you want to be able to answer those questions by saying, yep, we understand that, or thanks for pointing that out. I think we could measure this to safeguard that. And if we, you know, spot something there, then we can think again about what's going on. So yeah, it takes a long time to this step. So which measure is which? So in the chat, put your answers down for 1, 2, 3, balancing process or outcome for each of them. So the first one is an average number of times patients receive recommended oral care in 24 hours. Number 2 is patient and staff satisfaction scores. Number 3 is the rate of hospital-acquired pneumonia per 1,000 catheter days in the ICU. Thanks, Josh. Say number 1 is outcome, number 2 is balance, and number 3 is process. There's Sam, you think number 1 is process, number 2 is outcome, and number 3 is outcome. And Sally thinks outcome, process, and balancing. Regan says process, balance, outcome. So I would agree with Regan. The first one here, the goal of oral care is not to have oral care. The goal of oral care is to have, you know, a healthy mouth and gums and teeth and not have infections and stuff like that. So this is a process, and it's a process that happens every day. So it's a process measure. The second one, patient and staff satisfaction scores, is balancing. So that's where you get the complaints and stuff like that. And so an initiative, if it puts an undue burden on the staff, then your scores are going to go down. Number 3 is an outcome. So this is what we're trying to ultimately prevent here. We want to prevent somebody getting pneumonia. And if we do, then we have achieved our goal. Okay, so this third question there is, what change will we make that will result in an improvement? In other words, what are we going to do? What's the new idea that we're going to try out? Okay, and there are many, many ways in which you can come up with ideas. And usually the best people to come up with the ideas are the people who see the problems every day, the people at the coal face. So there are lots of different things: process analysis tools, benchmarking, technological solutions, creative thinking, change concepts. I mean, and there's a much longer list. This is probably a good short list of sort of areas to look for ideas. A lot of it comes from lean. So eliminating waste. And that means waste in all sorts of areas: waste in time, waste in resources, and waste in money. So if you notice that staff are duplicating their efforts, like recording information in 2 different systems twice, for example, that's an example of waste. Improving workflow, so making things smoother, to go from one to the to the next in a logical way that passes one to the other without sort of too much distraction in between. Optimizing inventory. So the classic example of that is a drug cupboard that's either stuffed full and not in order and you can't find any drugs, or a drug cupboard that is poorly stocked and has never got the right stuff in it. Enhance the producer-customer relationship. So that's about, patient care basically, and also allowing the patients or the clients to be able to give feedback and to complain and stuff like that in a way that actually helps you change and improve. Changing the work environment. I mean, I'm not going to go through all these, but this is a good list of things that might help you. Maybe somebody could think, so we're in this scenario of what changes could we improve oral care in the ICU? So would that be to, in terms of one of these 5 categories, improving the workflow or optimizing inventory or changing the work environment, managing variation or designing systems to prevent errors? Can somebody unmute themselves and describe an example of a change idea in one of those categories that would help with oral care in an ICU?
How about design systems to prevent errors? How about a protocol or a flow chart saying patients need to have oral care every X amount of hours? Is that one?
Yep. I mean, that would be one. Yeah. So the flow chart would standardize the process. It would make it clear who was responsible at what time. And it might even have a feedback loop that if it didn't happen, there would be a way to flag that up. So yeah, and the example they gave there is the post-oral care protocol in visible places, so just as you said. So in the other areas, the examples that they give there are to improve the workflow, make sure the cleaning supplies are kept ready in a ready-to-go state, so you can just grab it and go. So you spend less time looking for the stuff you need. So optimize inventory, make sure that the equipment is readily available, obviously, consistently available, and it's easy to find. It's not in a huge room that's completely messy. Change the work environment, so train hospital staff on proper mouth cleaning technique and importance. So it's not changing the physical work environment here, it's changing the knowledge environment, I guess, by increasing the overall understanding amongst the staff. Managing variation, so this is where a policy is produced so that everybody does the same thing, and that also this policy is up to date with the recent evidence and guidelines. Okay, so the last step in the model for improvement is the PSA cycle. So you know what you want to achieve, you know how you're going to measure that achievement, you know what you're going to do, and now you want to test what you're going to do, and this is the PDSA. So it starts off with plan. So you want to plan a little test, and you want to start as small as possible. So it's usually best to start with one patient or maybe one ward area for one day or something. And the whole idea to start small is because then it's easy. It's really easy to just do one patient. It doesn't take a lot of planning. You don't need to tell many people about it. And if it doesn't work, it doesn't matter. You haven't lost much at all. But the bonus you get from that is you start to build momentum, and you start to build supporters for your project who've actually done something. And when you have confidence within all the staff group that you are wanting to help you with this project, it makes it so much easier to do the next cycle and the next cycle. And each time you do it, you get a little bigger. So you're going to plan this really small unit. You're going to try and predict what's going to happen when you plan when you do it. You're going to say when you're going to do it, what you're going to do, exactly what you're going to measure, and how we're going to evaluate it afterwards. So that's all in the plan. And then you do it and you observe what happens and you document the results. And then you study those results, either using little run charts, which you'll get to learn in subsequent modules on this course, and analyze the data to see, did it actually work? And another portion of data which is vital is actually just asking the staff who were involved, how did it work and what was wrong? And then ACT is basically designing what you're going to do next, because there will be improvements that you've learned from, there will be things you want to change, and things you want to keep. So that's the PDSA cycle. As I said, you start small and you build up. And the other point of starting small is that you don't need to wait a long time to begin. You can go on a hunch and a theory and test that out. But when you're getting bigger, you've already got some evidence behind you to say, no, this is likely to work, and I want your effort in this. So overall, model for improvement is setting an aim, establishing measures, identifying changes that you want to implement, then you want to test them until they're good enough, and then you implement them. So then that's when you go out to the wider group and say, right, we've tested it, it's working now, this is what we want everyone to do. So now I'm going to show you a video which is gives you an example in a rather non-healthcare, slightly eccentric way from the IHI, but it's quite interesting and funny to watch. I'm going to play this. I should work with the sound, but if you can't hear anything, just shout out, okay?
I'm going to talk to you today about Plan, Do, Study, Act cycles, commonly known as PDSA cycles. So let's just go over for a second what those terms mean. And I'll start by telling you that this is a method we use in science, we use it in everyday life, and we certainly use it in improving healthcare. So plan, by plan we mean we're going to run an experiment. We have a hypothesis, we're making a prediction about what will happen when we run this experiment, and we're going to determine whether or not that prediction holds up. That's where the do comes in. We run the experiment and then we study, that's the S. We see whether or not our prediction was in fact verified when we acted on our plan. Based on what we find on the data we get from the PDS, we then revise our plan if necessary and act to change our plan and have another hypothesis and run another experiment. So that's pretty simple, and you're probably seen many examples of this in healthcare, even if nobody called it a PDSA. Let's look at an example of trying to prevent central venous catheter-associated bloodstream infections, or CLABSIs. Now, we all know that a checklist has been shown to be very effective in getting folks to reliably do the right evidence-based practices when they put in a line, and that reduces infection. The question is, how do you actually get that done in practice? How do you execute on that evidence-based plan? Well, we know that among the things you're supposed to do when you put in a central venous catheter are to prep the skin with a certain kind of antiseptic, it's chlorhexidine, and to use a large surgical drape. Those are two of the elements of the checklist. The question is, how do you get them to be at the bedside reliably so that the care team has them at their beck and call when they're ready to put in the catheter? So the physician's ready to put in the catheter, and you have a theory that if you include the surgical drape and the antiseptic in the packet of supplies that the team brings to the bedside, the physician will always be able to do it. He won't have to be looking all over. She won't have to be hunting for these supplies. And that's your theory, and you predict this will improve care. So you do that experiment, and lo and behold, not surprisingly probably, the drape is there, the antiseptic is there, the physician uses them when he puts in the catheter, and infection's probably less likely. That's a PDSA cycle in healthcare. So I know you're dying to try this in healthcare, and that's great, but I recommend that first you try it in your own personal life so you get comfortable with it, so that when you go to healthcare, you'll feel like, I've done this before, this isn't that hard. But I'm going to talk about, of all things, cucumbers. And I care about vegetables. I have raised beds. I spend a lot of time and effort. I don't want stuff to go wrong. So this year I decided I'm going to plant cucumbers and prepared the soil, put in the fertilizer, dropped in the seeds, 3 seeds to a hill. They sprouted. I thinned them to 1. Things growing like crazy. And I running it along my bed and looking at it with admiration. I come back from work to home, and I see that it's been chopped off by a weed whacker. Turns out every Monday there's a guy that comes and he does our lawn, right? And he has a weed whacker and he chopped off my cucumber. And this results in a pretty stunted cucumber. So I said, well, look, I have a theory that if I prop this cucumber vine up on the raised bed more carefully, the weed whacker won't get to it. That's my prediction. And so I put the cucumber vine up on the raised bed, came back. By golly, the head was chopped off again. My prediction was not correct. When I studied the result, it was a disaster for my poor cucumber. And so I had to revise my plan. I had to act in a different way. My next experiment was to put a large flower pot in front of the cucumber vine, hoping that the guy with the weed whacker would understand that he wasn't supposed to meddle with this thing. And lo and behold, I come back, another PDSA cycle failed, and he'd been mangling my cucumber again. At this point, I actually thought about something that you probably use in your life, and we certainly sometimes default to in healthcare, and that's called brute force. I went to find the guy, the weed whacker guy, and basically grab him by the shoulders and shake him and saying, you're killing my cucumber. But I restrained myself. This is improvement. We don't want to have blame. We want to do things better and make things better for the weed whacker guy as well as myself. So my next PDSA cycle was to put the cucumber up on a trellis. I figured if I had a trellis, and I have a very pretty one, as you can see, it's in the shape of a leaf. It's really quite attractive. I propped the cucumber up on that so that a weed whacker really couldn't reach it. And lo and behold, look at it, it thrived. My prediction was get the thing out of the way so that the weed whacker absolutely can't get to it. This is called a forcing function. The forcing function is the darn weed whacker just won't get that high. He can't do it. And my cucumber's thriving, and I'm telling you, I had the best marinated cucumbers, a little onion, salt and vinegar last night, just like my mom used to make it. This was a really good PDSA cycle. So that's all there is to it. You can do that in your own life. You can do it in healthcare. Remember, you have to have a prediction. You have to start with a theory. Your job is to see whether or not your theory is a good theory. Most of our theories, we have some doubt, so go test it. Run a PDSA.
There you go. So if you like growing cucumbers, there's some advice for you. So now we're going to have a little fun in some breakout rooms, designing your own QI project. So I would say select something small in your work or your home. So it could be a cucumber bed that you think could be improved. And I want you to apply the model for improvement to it. So go through the steps of asking the 3 questions and then thinking about how you might do your first PDSA cycle. You don't all need to come up with ideas, but I think, if somebody's got an idea in the breakout room, then it'd be good to bounce your idea off the others in that breakout room, and the others can kind of like probe a bit and ask you questions about, how would this happen, and how would that happen, and what measure do you think would be good, and which one do you think would be better, So I'm going to open up the breakout rooms. Okay, so there's going to be about 5 people in each room, but again, Not everybody needs to come up with an idea. And we're gonna sort of like run that for about 10 minutes, which then will take us to about 10 to, and then we'll spend, well, maybe make it 8 minutes, and then we'll spend a little bit of time just going through one of the ideas from somebody back in the main room. Okay, so here we go. Welcome back. We're just waiting for the others to come through, and then we'll have a chat. Here they come. Welcome back, everybody. We've almost got everybody back, just waiting for everyone to come back. That's great. Just gonna see if this works. We're all sitting in a classroom now. I don't know if you can see that. Does anybody have a particularly passionate QI project that they want to talk about? You can either unmute and shout out or put something in the chat. You want to put your hand up?
We decided to look at how to get the kids to pick the towels off the bathroom floor.
Oh, the towels off the bathroom floor, yes. So yeah, fantastic.
So we felt that was we had a sort of aim to get them to do that. So we felt it was reasonably smart, although I'm not sure that it was realistic. And we came to the conclusion that it kind of depended a little bit on the population. So one of the members of the team, sorry, I don't remember your name, had young kids, and some of us had older kids, you know, so teenagers. And we felt that actually it was, you know, the younger kids might respond to different approaches to the older kids. So in the end, we decided to sort of stick to teenagers.
Okay.
and we decided to do a little PDSA type cycle where we would, we came up with a couple of, not many, because I think we've all been there and tried and failed repeatedly, but we came up with a couple of things. And one of those was some sort of bribe or incentive, as that we'd use that as the first little, PDSA cycle. And we'd probably start with just one child, one teenager maybe, that might be a bit more amenable to the and see how we got on with that. And obviously it's possible to have measures in terms of numbers of towels picked up or not picked up. And yeah,
that's great. Yeah, good. And did your group come up with any other interesting ideas to test other than incentives?
Linking it to the Wi-Fi was the biggest one. Or linking to pocket money. We also thought about other things like making sure that there were laundry baskets provided, but we didn't think that would really probably. So we decided to concentrate on the bribe as the first kind of step. I don't know if anybody else in the group wants to just kind of say anything, but yeah.
Yeah, no, that's a great little example. And I like how you thought of other things like, changing the environment, washing basket, as well as incentives. And maybe there was some deterrence in there too, like punishments or something.
Making them not giving them any fresh towels, and then they were going to have to use a stay mold stinky towel unless they did the washing themselves.
Yeah, good. I like the use of natural consequences. That's that's definitely something in the parenting world. Absolutely. Yep. Good. Well, thanks very much. That's a really great example. Thinking through the things, it would be one thing that's good is to really nail that SMART objective. So, you would want a deadline. You would maybe estimate, how often does this happen? I know that maybe your outcome measure would be a number of towels picked up. So how many are you going to reduce that by? And you'd stick that all in your aim so that it's very clear. Good. So do we have another example that somebody wants to share just before the end of this session?
We'd it's more work related one. We had one around trying to remove out of date forms from wards. So trying to get people to use the current forms. So we went through the list of what we're trying to accomplish. We a key part of this would be making it measurable. So we'd have to find, what is the percentage of out of date forms being used in a particular area, and then you'd be looking to say improve that. Say if it's 20%, in 3 months' time, you'd be looking to reduce that down to say 10% or 5%. And the very good advice from the group was it'd be great to start small with this. So you'd be potentially looking at one form in a particular ward and trying a range of interventions that would range from trying to better communicate to the ward what the correct version is, or an alternative intervention would be to have someone external just come in and replace all the forms and actually go through. So you could trial at least those two different things.
Good. And so the last change idea that you said, what type of intervention would that be called? Can you remember from the video?
Of having someone external come in and
or actually of it's a forcing function, isn't it? So it's where you're actually preventing anything but the correct form being used by just removing everything else from circulation. Yeah. So out of all those things, the forcing function would be the most effective thing, and you can guarantee that if you take away all the forms, your project is going to be 100% successful there. So yeah, either somebody physically coming in, or if you're talking about electronic forms, and it's just simply a case of removing access to that electronic form, isn't it? So yeah, very good. Okay, so we're now at 5 to 1. I don't want to keep you late. Are there any questions from anybody from the group or anything people want to talk about before we go?
Just a very quick question, James, please. With the cycle and so on, and the process where it goes from aim to implementation.
Yes.
Where does ongoing evaluation and monitoring fit into that?
So that comes, I mean, ongoing evaluation and monitoring suggests to me that that's the point at which you've got something that you want to implement across the organization. Is that what you mean?
Well, as with any quality improvement, and you've gone through all these cycles, and you feel that it works, it's still important to keep reviewing that and monitoring that it is still being done correctly or whatever. Or are there any other things that have because you might do it for, I don't know, as a you might do a PSA cycle, and you might then implement it after just for example a couple of months. Well, what about a year down the line or 2 years down the line?
So once your intervention is established in all the areas you want it in, then it's no longer an improvement project, because you're no longer changing anything. So at that stage, you're in a different phase, and you're well past the model for improvement at that point. You're in the business as usual, some people call it, or the operations phase. And then that is down to management of the process. And there are lots of management things such as dashboards and regular quality meetings, and lots of, like, for example, a clinical governance framework would be a very nice thing to have to ensure that all your processes that you've put in place remain as you expect them to be. And if they come out of kilter, then that framework, that clinical governance framework, would pick up something going wrong and flag that up either to a quality improvement team again to go in and diagnose what's going on, and maybe make some further changes at that point. But the point that you're talking about, the monitoring and the ongoing quality assurance and stuff, is actually past the point of improvement.
I guess that's what I'm saying. To me, it's still quality. It's quality assurance rather than quality improvement. I mean, it might lead to further quality improvement, but okay, that's the distinction.
Yeah. So improvement itself is about change. And once you're no longer trying to change something, then it's no longer improvement.
Okay. Yeah.
Any other questions? Great. Well, if you got any questions for me individually, you can just hang on at the end of this call. But very good to see all of you. I hope you enjoyed that session, and I'll see you later on at the end of this month for the next one, where we start to dive into some of the statistics of it all. Okay.
Thanks, James.
Cheerio.
Thanks very much.
Thank you.
You're welcome.
Thanks. Bye.
Bye-bye.